Anatomy of neck spaces. Neck spaces are very important structures. We need to know in radiology what are these spaces and how they are important clinically. So this talk has been delivered before as well. This is totally clinical oriented, and this is for all the residents who are like in first or second year of their training and learning anatomy. Well, third and fourth year I usually know these things since they're reporting CT and MR. For videographers and other medical professionals who need to know a little bit of radiological anatomy. So I will be basically touching more of MR as far as the neck spaces are concerned. So these neck spaces are called cervical spaces. And what these are basically the facial plane and compartments in the neck. Neck being a very complex structure. It has many communications like spaces, neovascular bundle, bones which are communicating above with the head and down with the thorax. So what we need to know is how these spaces are divided, and importance of these spaces will be to localize the lesion, in which space they are, and how it can affect other spaces, and how we can localize that where the epicenter of the disease is. The second thing is narrow down the list of differential possibilities which are potentially found in one space and not in the other space. And as a radiology person, it is very important for you to know and then report clearly in your reporting that which space is involved and what are the secondary features which are causing issues to the patient in different spaces. So in our report, what we clearly should mention in which space the pathology is or the lesion is. Second, we should have a sound knowledge of what are the normal contents of this space. Basically, when we know which space it is and what are the contents, so it will be very easy for us to understand what pathologies can be there in this very particular space and how they can transfer to the next one. And lastly, obviously, being super specialized in radiological patterns, recognition, integration of the clinical information, that should be very clear while reporting a neck MR or CT. Okay, the neck is divided into suprahyoid and infrahyoid neck in surgical, clinical, or in radiological terminologies. Suprahyoid neck is the one which is above the level of hyoid bone. This has few spaces like carotid space, masticator space, and buccal space. Actually, the masticator space and the buccal space, they merge together to form one space, and disease can, come back and forth in any of these two spaces. Submandibular space, its name is telling, is below the mandible, and submandibular gland will be there, and parapharyngeal space. Infrahyoid neck is below the hyoid levels, so we have anterior cervical space, suprasternal strap muscles that is just below the neck, and these structures are communicating with the thoracic inlet. And then we have suprahyoid and infrahyoid neck. Now note down, most of the spaces are in this category. These are the spaces which communicate with each other at both the levels. Above the hyoid and below the hyoid contains carotid space, Bristol space, pharyngeal space, retropharyngeal space, and a danger space, which is very important clinically. Pre-vertebral space, posterior cervical space, and trapezius sternocleidomastoid muscle is there, the space around it. So we need to know all these spaces. Not necessarily you memorize it like today, there and then, but sound knowledge of how to recognize this space. That's basic aim of this talk. So this is one diagrammatic representation of supra and infrahyoid neck. You can see this is hyoid bone, so anything above it will be suprahyoid, and anything below it will be infrahyoid. and few spaces which are communicating above and below. There are neck triangles, which are very favorite for surgeons: anterior triangle of the neck, posterior triangle of the neck. All the triangles of the neck, they are infrahyoid, and the muscles, trapezius, sternocleidomastoid, clavicle, above the thoracic inlet, these 3-4 structures, and the digastric, they form the boundaries of those neck triangles. In radiology, we don't mention those triangles. We have to be very specific in terms of spaces. Now, starting from above to below, pharyngeal mucosal space, it's a mucosa lining and structure deep to the mucosa of nasopharynx, oropharynx, cell lining pharynx. Now, this diagram is a sagittal CT post-contrast image of neck. Basically, neck, we do include like the inferior part of the orbit of frontal sinus till the level of thoracic inlet in radiology. How the pharynx is divided into naso, oro, and hypopharynx. That is important. So, in this slide, I will be telling you how to differentiate. So, this part is the posterior one, is the pharyngeal space. Now, how to divide it in nasopharynx? The nasopharynx will start from the base of skull. This is sphenoid area, that's clivus, and that's the cervical cord. So this is C1 level, and that's clivus, as I told you. At the base of skull level, the nasopharynx start, and it comes down till the level of soft palate. Now that's the nose. This is hard palate, and that's soft palate. This is tongue. These are the intrinsic muscles now. Okay, this soft palate, till the level of this soft palate, this whole space where my arrow is indicating is nasopharynx. Now, from the lower part of the soft palate till the epiglottis, this is epiglottis. This part is oropharynx. Now, note down, behind the nose is nasopharynx, behind the oral cavity or behind the tongue is the oropharynx, and from the epiglottis till the level of cricoid above, just aryepiglottic fold is there. Till that aryepiglottic fold, we have the hypopharynx, which is smallest craniocaudally as the pharynx, part of the pharynx. Now, from hypopharynx down starts the cervical esophagus. This is a collapsed structure. Anteriorly, we have larynx, laryngeal cartilages lie over here. This is cricoid cartilage. Anteriorly, we have thyroid cartilage, and then trachea starts. So, pharynx is divided into naso, oro, and hypopharynx. In the mucosal lining along it's the pharyngeal or parapharyngeal space. Now, this is axial images. These are axial images. T1 pre-contrast images of MRI from down to above. How down to above? This is the hyoid bone. If you see this landmark, that's hard palate, and this is the level of nose. So from down till above, we do see this lining, which is colored as a purple one, is the pharyngeal space. So it includes the mucosal lining here, anteriorly and posteriorly, behind the tongue and along this pharyngeal area. This is like air within the oropharyngeal cavity, posterior to the alveolar arch. These are the teeth, the upper teeth, and this space continues till posteriorly. Sorry, I need to add people, side by side as well. Okay, above, if we move above, this is nasopharyngeal space. Behind the nasal cavity, that's the midline warmer bone, and this purple area is the nasopharyngeal space. So these three slices showing the pharyngeal space going all the way in line. Now, what are the contents of this space? Squamous mucosa, lymphoid tissue, Waldeye's ring. Waldeye's ring is, is a soft tissue which is made up of lymphoid tissue, and it include tonsils and tonsillar pillars, etc. Minor salivary glands behind the tongue are there. Cartilaginous portion of this tissue and tube, I will show you where it is. Superior middle pharyngeal constrictor muscles is just behind the pharyngeal wall, and levator palatine is at the palatine muscle. Okay, parapharyngeal space, also known as pre-styloid and lateral pharyngeal space or pharyngeomaxillary face, is the name of the same space. Its para word is used for the space which is lateral to the pharynx. The one I've shown you, lateral to those on both sides, right and left, are the parapharyngeal spaces. So narrowly, the fibrofatty space between the degurgitation, like levator and palatini, these are the muscles and masticator muscles. So it's basically contain the fibrofatty tissue. I will show you what it is, but let's see what are the contents superiorly and inferiorly, how it is related to those. Superiorly, it's like close junction of the palate muscles at the base of skull near the foramen lacrum. So superiorly something is base of skull, and the pathology here in the parapharyngeal can be related above with the base of skull and palate area. Posteriorly by styloglossus, that means with the tongue. Inferiorly, it is continuous with the submandibular space. So that is something, all the areas are in the suprahyoid region, as its parapharyngeal space is entirely suprahyoid. How? Now see, that's the one in purple which I showed you at this level is pharyngeal space. Just a minute, I am getting a message that people are not being added up. Okay, so this pharyngeal space lateral to this area, this blue one which you can see, is the fibrofatty, basically contains fat. This is a T1 image. Now on T1 you can see this boundary. This is the fat of the face. This is fat. Now the fat appears white on T1. If we see just with these color coding things, that's the pharyngeal mucosal lining, this one, and that's the air within it. That's the pharyngeal space. Now lateral to this white thing, whole one, is fat which appears white. This is parapharyngeal space. So it is anterior, posterior, medial, lateral, superior, inferior. So with every space you have such contents which are interconnected. Whenever there is a pathology in pharyngeal space, you have to tell its superior extent, inferior extent, anterior, posterior, medial, lateral, everything. Similarly with the parapharyngeal space. Now if you note, there were 3 names of it. Surgeons like to call it like pharyngeomaxillary area, something like that. The radiation oncologists, they divide it into pre-styloid and post-styloid. Here somewhere here is a styloid process, like a bony chip, which is a longitudinal one. This area is anterior to styloid area. This whole area, pharyngeal, parapharyngeal, and behind is the post-styloid area. Because of the radiation field set in while treating patients, they have styloid process as a hallmark. So anterior to that is pre-styloid, posterior is a post-styloid, and there are nodes in these areas, pre-styloid and post-styloid. So that is a terminology they want to listen. Okay, now on coronal image, this is a CT image, and that's T1 pre-contrast, T2 image of the MRI. Now see, the fat appears black on CT. So this fatty area, this hole, is the parapharyngeal space. Now that's the pharyngeal mucosa, which is within the pharyngeal space, and lateral to this is a blacker one, the fibrofatty thing, which is a parapharyngeal space. Now on MR we have these muscles. This is pharyngeal area, and this whiter thing is the parapharyngeal space on both sides. Para mean on the sides of pharyngeal area. Now the contents are fat, internal maxillary arteries, and pharyngeal artery, pharyngeal venous plexus, and branches. Third division of the fifth cranium. Now we don't need to see all these structures and comment upon this. Whenever there's a pathology, if there is a tumor suppose lying in the parapharyngeal space and there are nodes, they just appear as pathology on T2 as a different signal change. On MR we detect the signal change inherently. If we know the signal change, that will be altered on MR. Basically, whenever there is involvement of the parapharyngeal space, the fat planes are gone. That means this fat thing, blacker thing, will be no more seen, and the whiter thing on MR will be no more seen. Okay, so what are the common pathologies that go to this parapharyngeal space? Because the potential fatty space, nasopharyngeal carcinomas, infratemporal metastases, the temporal region, I just told you before that it is somewhere related superiorly to the base of skull. See, superiorly this is base of skull area, medially it's the nasopharynx, laterally at the thyroid muscle, and submandibular area. This fatty thing, this all is parapharyngeal area. So below it's the submandibular space. Like this is submandibular gland. So white thing is going all the way till down here. So parotid tumors or submandibular tumors and carotid space lesions. When we will discuss the carotid space, I will tell you what are the lesions there. So they all can go into parapharyngeal space. That means superiorly, inferiorly, on both sides, anteriorly, posteriorly, all the things which can give tumors or abscesses or whatsoever the lesions, they can go and infiltrate the parapharyngeal space. So what will happen? We need to know the space, and the fat plane will be go. The fat thing will be lost. Okay, this is one of the examples. This is post-contrast T1 image. We can see something enhancing here, enhancing vessels. This is taken at the level of nose. These are the turbinates and these are maxillary sinuses. Now that's nasopharynx. If you see, there is some asymmetry in this area as compared to this one. The fat will appear blacker on this. Just compare the fat out and fat inside here. Okay, that's the mucosal lining of the pharynx or the pharyngeal space, and that's the parapharyngeal space. This dip within this mucosal lining and this opening, that's the Eustachian tube, the cartilaginous part of the Eustachian tube is there. This dip is called the fossa of Rosenmuller. Now, this patient has a nasopharyngeal tumor on this side. It's at the left nose. Nasopharyngeal tumor. This is enhancing tumor which is going down till here, extending posteriorly into the longus colli or the base of skull area. This enhancement is also tumor. This all enhancement is also tumor. Now see, the black thing on this side is gone. So relatively you have to compare with the other side. So this whole thing is tumor, and it has infiltrated into the parapharyngeal space. So pharyngeal space is a nasopharyngeal tumor which is extending into another space. Because of the Eustachian tube involvement, there will be mastocytitis and stuff like that, which you need to see. So this is just to show you an example that the pathology will look like this. It will be obliterating the normal signal patterns on both sides. Okay, this is a schematic diagram which is showing a pathology, and here is the CT axial image post contrast. So not a very good quality, but it's like obscuring the things, how it is being done. Now this is pharyngeal space. All right, that's muscle, and if you compare this side with this side, now note down, this is a tumor. This is something, a growth, which is abnormal on this side. It's not present on this side. So it is going through the parapharyngeal space and causing some indentation or mass effect, like it's pushing this area if we compare from the midline towards the medial edge. Here is the same thing shown in this diagram, that this is causing pushing the mucosa towards this side, and that's something abnormal as we compare to the opposite side. And note down that this black space is a parapharyngeal space. This is black, this is black. Now on this side, this is lost. So there is a tumor which is involving the parapharyngeal space. Now we have to decide where it is coming from. Obviously, if there is a lipoma, because of lipoma is a fat containing tumor, then there is that's fine, it's likely arising from it. But this tumor doesn't look like a lipoma, it is coming from another space, maybe parotid or any other area. Now carotid space, if we move a bit more laterally, we started from the midline pharyngeal space, went on the sides of the parapharyngeal space or the pre-styloid area, and then move more laterally on different towards both sides, we have carotid space. And carotid space is one of the space which contains carotid artery. So now carotid artery is running all the way from skull base till down in the inlet. So make sure, note down, it has two levels, suprahyoid and infrahyoid both. The ones we read before, like pharyngeal, parapharyngeal spaces, they are entirely suprahyoid. Now it extends from the skull base to aortic arch, suprahyoid level. It's posterior pharyngeal or retrostyloid space. So at the level of suprahyoid, it is posterior to the parapharyngeal, like a little bit more posterior and lateral to it. It has stylopharyngeal fascia anteriorly, pharyngeal wall anteromedially, pre-vertebral fascia posteriorly. I will show you what it is. At hyoid and infrahyoid level, there are sternocleidomastoid and thyroid. There is a visceral space medially which contain, the visceral name is telling it contains viscera, and posteriorly vertebral column longus and anterior scalene muscles. Now these two images are showing, this upper one is at the level above the hyoid or suprahyoid level, and this is below the level of hyoid bone, the infrahyoid part of it. Now we saw this pharyngeal space in the midline, and the fat-like thing is the parapharyngeal space. If you move a little bit more lateral out and lateral and posteriorly, these are the two black dots. These black dots are signal voids, like the flow thing which MR doesn't detect. These are two vessels, carotid artery and internal jugular vein. So these two are the ones, and there's a little bit of nerve over here as well. These two make the carotid space. So it is all the way from up coming down till here. These two structures, these two black dots, carotid artery and internal jugular vein, they're coming down as well. Now if you see anteriorly is this parapharyngeal or fat containing space. Here are the muscles, these are the pre-vertebral areas, the spinal cord actually. Laterally we see this is parotid gland, and anteriorly are the muscles as well. And at the level below the hyoid, we have this visceral space which contains the thyroid, esophagus, trachea. These three are viscera, so that's a visceral space here. Posteriorly are the muscles, anteriorly are the scalene muscles. These are the strap muscles of the neck. So this space is continuous all the way from above downward. So any tumor which is related to this, like carotid sheath or carotid nerve body tumors, they will be in this space. Okay, so this is a CT image which has marked both the vessels, and that's to show you the carotid space. Now the contents are like carotid artery, so any aneurysm, thrombosis, dissection, internal jugular vein, thrombus or thrombophlebitis, vagus nerve, it has a schwannoma or neurofibroma of the nerve will be there in this space. Sympathetic plexus may have paraganglioma, lymph node can be there. Lymph nodes can be anywhere actually in the body. So lymphoma or metastases, and congenital remnants at times, second branchial left cleft cyst can be there. Okay, so how does this pathology go? Suppose the neurogenic tumors or tumor of lymph nodes. So what they're going to do is go back to the midline. This is pharyngeal space, and the parapharyngeal space is a white thing. Then is the carotid space. Now you see the carotid contents over here, these two black dots which I showed you, the two vessels and some nerves. There is no such structure seen. So something is coming from carotid space. So tumors which come from here, now see, they are indenting into the parapharyngeal space. There is a little bit of push on this side. There's nothing, like no tumor here, no push here. So from carotid space to parapharyngeal space, something is extending. Now it's our duty to tell from where the pathology is coming from. The push on this muscle is a secondary feature. This doesn't mean that it is coming from pharyngeal space or parapharyngeal space. So we need to look into the space posteriorly as well, related space. So there is something wrong with this space, and that is causing secondary effect on this space. Sorry, the running time will be there. There will be a little bit of gap between the presentation. Okay, that's example of a carotid body tumor which is in the carotid space, and it is typically between the two branches, external and internal carotid artery, that displays it actually. So if we see this is carotid artery, that's internal and external. So the tumor basically lies between the two vessels. So that's typical of carotid body tumor, lying within this space, not going out. Now buccal space, it's above the hyoid. It's a deep facial layer adjacent to the maxillary ridge. Basically it is along the teeth, the buccal region, the gums where we have. So it contains buccinator muscle, superficial muscle of facial expression, including deep cervical fascia, and posteriorly the mandible muscles of mastication. The chewing muscles are basically within this area. So basically this space, this orange one, is buccal space. Here, this one. How we need to identify this thing, that we have to see the teeth. This is alveolar arch and so many teeth around it. So there are some muscles over here, and then there is fat, the white thing. Remember, see this thing and then see anteriorly. So there is this buccal space. Now any tumor of the gums of this muscle, or any bony tumor or anything from out going into this space, and there will be loss of this white fat thing, that will be within the buccal space. So posteriorly it has communication with the masticator space. Now where the masticator space is, let me show you right now so that there's no little bit confusion. This space I told you is the buccal space. Now posteriorly this is a masticator muscle. This is within the masticator space. Now this blends or meets up with this space. There's no clear-cut demarcation where the space starts and ends. Like parapharyngeal space, this is white, and we know there's posteriorly is the carotid space, and there's no little demarcation between the buccal space and the masticator space, so it blends with it. Superiorly, there is fat of the temporal fossa, so infratemporal extension is there. Inferiorly, no true boundary between the submandibular space and the buccal space. So basically the buccal space is like a communicating with all these other spaces. So lack of boundaries is important, because it's a pathway for spread of infection to and from the buccal space. So if there is involvement of the buccal space, there is involvement of other spaces as well. So that makes it a potentially dangerous space. It has fat, it has parotid duct. So tumors of parotid duct or any parotid duct pathology like solidinitis or silolithiasis, that is going to affect this space. Facial vessels, accessory parotid bubbles, and minor salivary glands. So you can't ignore the buccal space and the shared spaces around it. So that's remains an issue. Okay, parotid duct calculi, as I told you, odontogenic infections, maybe dental infection related to the teeth can go into it, and minor salivary gland tumors which are there. Now masticator space, it contains the muscle of mastication enveloped by the fascia. It is continuous superiorly with the temporal fossa, posteriorly back to edge with the mandibular ramus, anteriorly to the anterior ramus, and superiorly to the base of skull. Then the mandible divides the space into medial and lateral compartments. How? So that's the masticator space. Let me show you how it is divided into medial and lateral. Now we have this buccal space which blends with it. we have this parapharyngeal space, carotid space. Now this whole area, if you just follow my arrows, this whole area is the masticator space. This whole a little bit more low muscular area. So they are pterygoid muscle, then masticator muscle, and what is this? This is mandibular ramus. Now this is dividing into lateral part and medial part. In the medial one, towards the body, is there are muscles, and laterally there is also a muscle, but it is divided into these two parts. So this whole space is masticator space. Now here you see this muscle, and that's the mandibular ramus. This one. So below the mandible is the mandibular glands bilaterally, and then salivary glands are over here. So this part is dividing into the medial one and the lateral one. It's the ramus of the mandible. Now what happens is, muscles of mastication are there, ramus of the mandible is there, branches of mandibular vein, trigeminal nerve. So this space is basically any muscular pathology going on, it will be involved, or buccal space lesions or submandibular lesions can go and infiltrate into it. This is usually a site of secondary pathologies rather than the true ones. Parotid space. The name is telling it contains the parotid gland enclosed by superficial layer of the fascia. It has parotid duct and its duct, parotid gland and its duct, interparotid nodes. Interparotid nodes are very dodgy and controversial topic. In children, we do have interparotid nodes. There are many, actually more than 20 interparotid nodes can be there. Lymphoma has a propensity to involve the interparotid nodes, and I have seen so many cases involving the parotid glands. So parotid involvement can be very smooth, and lymphomas can have nodes, or different other tumors can be there. External carotid artery and internal maxillary artery branches, retromandibular vein. That's basically within this substance of the parotid gland, and fascial nerve obviously is there. Whenever you have parotid duct pathology, you need to comment on the fascial nerve, or you can just recommend clinically see the parotid features. Okay. This space is behind the masticator space. Now this is masticator space, medial, lateral, and mandible. This gland, which is a little bit more brighter signal as compared to the muscle, is the parotid gland. This one. Okay. Now that's mandible, and behind the mandible is retromandibular vein. The name tells this is retromandibular vein, this black dot. This vein passing like this. So there's a nerve fascia nerve probably over here that is more superficial to the vein. It's like contrary to the body rules. So this retromandibular vein is going to divide the gland into medial, deep and superficial parts. So the part of the gland which is like medial to this more inner one is a deep part of the parotid gland. That's the one which is lateral to this is a superficial part of the parotid gland. Now this space is bounded just because of this parotid area and parotid gland. Now the signal intensity will tell us that both the spaces have different contents. This is parotid gland hole on the coronal images, anterior and a little bit posterior one. Now the third space, next space is the mandibular space. It obviously contains a mandibular gland, a mylohyoid muscle. It cleaves the lower oral cavity into some lingual and some mandibular spaces, and superficial to mylohyoid. Where this space is, let's see. Its contents are the superficial part of the mandibular gland, obviously the belly of the gastric and submandibular nodes, submandibular nodes. These are cervical level 1, A and B nodes, facial artery, vein, cranial nerve. So location is it's deep to mylohyoid. Anteriorly we have hyoglossus muscle, lingual nerve, cranial nerves 9 and 12, lingual artery and veins, mandibular ducts, deep portion of the mandibular gland and duct, and posterior communicative with the space around the tumor. Okay, less than 1 minute is left, so I will just wind up and then I will rejoin through the Zoom because it's giving me an alarm that less than 1 minute is left. Okay, this is the submandibular area, and that's the submandibular gland. You can see bilaterally symmetrical soft tissues. If we move a little bit more anteriorly, there's a fat, and submental and submandibular nodes will be here. This is tongue area, and we can see these two small dot structures. These are sublingual glands. Here we can see more clearly, these are the sublingual glands. Like this is tongue, below the tongue is a sublingual area. So here are the two glands and digestive muscle bodies, bellies, sorry. Okay, retropharyngeal space. Now the next space is retropharyngeal space. Can you guys hear me? Can anyone just type yes or no? Okay, thank you. Okay, the next space is a retropharyngeal space, which is behind the pharyngeal area. It's bounded by the middle and deep layers of the cervical fascia and extends from skull base to mediastinum at the level of T2 to 6, where two layers of the cervical fascia fuse together. It's a lateral wall made up of slip of fascia known as alar fascia, and it has a midline raphe. Now, where it is, that's important. Retropharyngeal space is actually one of the most favorite spaces for infection to travel, and it becomes a dilemma for most of the ENT surgeons to drain, collections or infection from it. So the contents are lymph node and fat only, and in infrahyoid portion there's only just fat. So basically it's a potential space which, it's a narrow one. Infection can travel above and below. Basically, that's the retropharyngeal phase. Retro means behind the pharynx, so that's a little bit potential space which does not, it's not very much appreciable in imaging until unless there is a pathology. So fat is like lipoma, liposarcoma, and channel for infection tumor travel to mediastinum. Now this is the best which one can assume like this. That's clivus and spine. That's the pharyngeal space. Retropharyngeal space travels all the way down till here in the mediastinum. Now posteriorly a little bit is a pre-vertebral space interior to the vertebra. That is another space. So this red one is a retropharyngeal. We do call it as a danger space as well. So basically what happens is when there is a retropharyngeal abscess or tumor or something, this black thing, then it becomes more apparent like this. A lymph node becomes more apparent. Okay, now how does it look whenever there's an abscess or pathology or node, something like that? That will appear like this. In front of the vertebra there is these nodes and all that stuff. So the carotid contents will be maintained, parapharyngeal space will be there, anterior spaces will be there, but this space will be visible only whenever there's a pathology. Danger space is basically the same space. It's potential space behind the retropharyngeal space, and this, it's like a misnomer for that. So danger means something very pathological, very dangerous and difficult to treat it. So the retropharyngeal or danger space areas are, one and the same, and it's indistinguishable from the retropharyngeal space in healthy patients. So basically it also distance fluid pass below the level of T1 to T6. So the infection will travel into the chest, and it will be really, really, really difficult to treat it. Pre-vertebral space, also known as paraspinal space. So it is proper one anterior to the compartment along with it, and posterior paraspinal space. So basically this large space on this diagram, we have this pharyngeal space. Let me just summarize a little bit. And parapharyngeal space, and carotid space. Anteriorly we had the other spaces, buccal, masticated. This whole thing in the posterior aspect, it has muscles, small vessels, vertebra, spinal cord, and all this all is pre-vertebral space. And now see these two dots, which are like carotids and internal jugular vein. This whole thing, this big one, half of the posterior half of the neck is prevertebral paraspinal or muscular space of the neck. So that's even better seen here. So that the pathology is here. We can arise. We see vertebra, we see vessels, we see nerves here and muscles. So whenever there's osteomyelitis of the vertebra, prime bone tumor, metastasis, muscles, we have myositis, abscess, sarcoma, fibromatosis things. Brachial plexus, it arises from the nerves. The nerves in the cervical region there can give rise to, schwannomas, neurofibromas, and nerve sheath, peripheral nerve sheath mix type. Vertebral artery and vein can have aneurysm, dissection, thrombosis. The vertebral artery will, travel through this vertebral foramina. So go with the contents, you will find the pathologies. For example, to give you an example like this, it can has effect on the paraspinal spaces, schwannomas. This is spinal cord, that's vertebral body, lamina and pedicle. So from here we have the exit nerve root from where this paraspinal mass schwannoma will arising. Now how to differentiate it? It's like from here, not from any other space. We see muscles over here anterior to this. So anything between the muscles is always in the paraspinal or paravertebral space. So it has pushed the carotid space anteriorly, but still we can see the muscles. It has not lost the its content basically. So this space, carotid one, is more preserved as compared to this one because there is a tumor over here. So now these are the references for if you want to read more about the spaces. I've taken the images and all the content from Radiopedia. I was radiology assistant, so you can read more about this floor of mouth and sublingual space, about radiographics, CT of the carotid space, and related cervical spaces. This was just a little bit of overview how to recognize different spaces and how to take it from anatomy till recognizing the pathologies. In my subsequent lectures, I will be showing pathology of each of the spaces differently, especially tumor-related things, and how to report nasopharyngeal tumor, oral tumor, buccal tumor, and various techniques. How do we do imaging, and what are the protocols, etc.